Good afternoon, everyone. We'll just wait as people are joining a few minutes. And I'll remind everybody to put themselves on mute unless they're going to ask a question. We still have people joining, so we'll just wait another minute or two. I guess we can go ahead and get started with introductions and such as people are joining. Welcome, everybody. This is our enrichment program for our Center for Improving Palliative Care for Adults with Multiple Chronic Conditions, which is funded by NINR. And I'm very excited today about our presentation about the use of psychedelics in palliative care. We have two fabulous experts in the area, Dr. Craig Blinderman. He's the director of the Adult Palliative Care Medicine Service here at Columbia and New York Presbyterian Hospital since 2010. He's an associate professor in medicine at the School of Medicine. He's previously been attending in palliative care services at Massachusetts General Hospital and co-directed the MGH Cancer Pain Clinic. Also, we have here Dr. Carl Hart. He's a professor that's published numerous scientific and popular articles in the area of neuropsychopharmacology, and he served on multiple NIH grant review committees and multiple scientific journals, including Progress in Neurobiology and Addiction Neuroscience. He's co-author of the textbook Drug Society and Human Behavior with Charles Kerr. I probably said his name wrong. And he's expert in this area. So thank you both for being here. I'm very excited. For everybody else here, feel free to, this is going to be a discussion. I'll moderate, but feel free to use the chat or take yourself off mute if you have a question. You know, our speakers have said that they'll answer anything at any time. So let's start off with the basics, and I don't really care who answers this, but can you describe how psychedelics affect the brain?
I don't know, Carl, do you want to take this one? I'm happy to add my clinical sense of it, but I think you're gonna make more.
Sure.
the brain's a complex place. Let's start there.
No, sure. I think it's a great question, because one of the things that we do is we talk about drugs in the brain in order to oftentimes pretend that we know more than we know, and to act like experts. So when you say, how do psychedelics affect the brain? I know and I don't know. I know how many of them affect certain neurotransmitter systems. For example, some of these psychedelics that we're talking about, psilocybin being one of them, can act as an agonist at the serotonin H2A receptor. But really, that doesn't tell you much, but we pretend that it tells you a lot. Serotonin makes up less than 1% of the brain neurotransmitters, but we pretend as if that gives us a holistic picture of somebody's behavior. But we are learning more about how these and other substances affect the brains. And so when you say psychedelics, I think the first thing we have to do is take a step back and talk about, well, what do we mean when we say psychedelics? Because one of the things that has happened in today's world is that we have placed psychedelics aside, and we're busy in our popular culture rehabilitating the reputation of some of these substances like psilocybin, ayahuasca, which is DMT is the main substance in ayahuasca, where those substances are okay. And even MDMA, we're putting in that class of psychedelic. When in fact, MDMA is an amphetamine. It looks almost identical to methamphetamine with a slight modification. And so we use the term psychedelic to delineate the substances that the dominant culture is into at the moment, and to also to make sure we exclude other substances that the society is not into in the moment. And so when we're having this conversation, I guess people are talking about things like psilocybin, MDMA, and even ayahuasca. But when I think of these things, I try not to use the term psychedelic because I know what this exclusion means. And so I try and make sure I say psychoactive substances. Some people say, well, plant medicines, and how about plant medicines? Well, the ultimate plant medicine for me is the opium poppy, but it's not included here because of our current sort of vilification of that class of medications today. So we must first understand that our use of the term psychedelic is political. And when we start doing those sort of things, that means that we have in groups and out groups, and people are paying the price and people are benefiting. And so we have to make sure that's sort of the foundation that we come here with.
Well, we clearly mislabeled our talk today, our discussion. So, Craig, do you have anything that you want to add about psychoactive substances, which I'll try to
yeah I mean, well, I think just on a interesting literary or historical note, I mean, the term psychedelic was basically a neologism from Aldous Huxley that he had put together in a kind of rhyme that was having in a correspondence with a Dr. Humphrey Osmond, who had gone to Mexico and had used peyote and had this correspondence with him. And so Osmond writes to Huxley and says, to make this mundane world sublime, take half a graph of phantothine. And that didn't quite stick as a terminology for what these substances were, from our popular culture. And he responded, well, actually, that was Huxley who wrote that. And then Osmond responded and said, to fathom hell or soar angelic, just take a pinch of psychedelic. So it was in this kind of, little cheeky, rhymes back and forth between these two individuals. One a literary figure who'd also explored, through his work, the doors of perception. In any case, that's sort of just a little background for those that are interested in some of the historical or literary pieces of this. But yeah, I totally agree. I mean, I think it's worth whenever we're, I think that in a more general sense, just to echo Professor Hart's, commentary, in a more general sense, whenever we categorize anything, we're also leaving out other things, right? So this is part of our of how we do things, right? We often are excluding, sometimes wittingly and sometimes unwittingly, by virtue of putting things into certain categories, and then subcategories become more accepted for lots of reasons, and we can take issue with that. And I think it's important for us to be critical about what goes in one category versus another, and how certain kinds of popular media might endorse certain kinds of certain categories versus others. Another thing, just to get back to the mechanism, I agree. I don't think we know so much about even how the brain works. We have little glimpses about systems, and we try to use that to sort of justify why certain medications and this and that should be used, but we in fact don't really fully understand the complexity. One thing that I did find pretty interesting, though, and I think it may speak to, at least metaphorically, if not quite mechanistically, is this notion of what people call the default mode network of the brain, that somehow seems to be changing when individuals use these kinds of psychoactive substances, such that this sort of the sense of self, the sort of the ego-centered sense of a continuous self over time is largely thought to be, part of what the default mode network is doing. And some of these functional MRI studies and some other work has been looking at some of the changing, whether it be blood supply to the default mode network or its actual activity when subjects are undergoing these experiences with these kinds of substances. So I think that's really interesting, perhaps that there is something going on there, and maybe having other kinds of connections that take us away from what some people describe. And I think that's what's really interesting, the subjective experience of a dissolution of the self, right? When they talk about these mystical experiences or these numinous experiences, it's this kind of dissolution of the self, and maybe there is some connection there. We can hypothesize that has something to do with this default mode network being suppressed in some way.
Yeah, just be careful with that sort of thing, because the MRI studies, for example, we find what we're looking for. If you put heroin in that same context, I'm sure you can find a similar sort of thing under the right conditions. And so I think it's important that we do have this sort of dissolution of self and losing of the ego. I think all of those things are critically important, particularly for Americans who are so self-centered in general. So I think this is what I'm really saying is that many of us could benefit from some psychoactive treatments ourselves. But the point is that it's really good that people can get outside of themselves. And if you have medications that can help people do that, then we kind of used to call that kind of empathy. You think about other people and not so much yourself. And these substances certainly can do that. But we want to also understand that other substances, the ones that we vilify, like heroin or even cocaine, can do those kind of things too, but it's really about the conditions under which drug use occurs. And I should say that I'm really excited that the society is re-looking at or taking another look at these substances because there are people who are suffering who actually benefit from these therapies. So I want to make sure I'm on record saying that I am excited about this. But by that same token, I just want people to, as we reconsider these substances, also consider what we've done and what we've said about other substances.
Interesting point, really good point. Some of these substances are naturally occurring and have been around for centuries and been used by, other cultures throughout history. How do we learn from this past use and respect the cultures that and traditions that have used them? Can you speak to sort of the historical aspects?
Yeah, maybe I'm happy to start, take a stab at that. This is something that I've noticed and brought up in every meeting I've gone to where researchers are talking about using psychedelics or using these kinds of what some people call entheogens, another terminology that's often used, or these psychoactive substances that have been used in traditional healing ceremonies and spiritual practices of indigenous people, including the Mazatec people in Mexico and with psilocybin, certain Native American traditions here in our culture, in this country, including using mescaline containing peyote and ayahuasca in Brazil and so forth. So there's a number of places around the world, ibogaine also in Africa. So there's individuals who, consider some of these, what we call chemicals, that medicine, and have for many centuries, used these medicines for healing, spiritual and otherwise. To me, it seems like, first of all, on one level, there is a long history and understanding. So it makes sense to partner with and learn from those who have, centuries of experience that have been passed down to, through these medicine men or spiritual leaders, shamans, sometimes they're called, that have been tasked with carrying this tradition over time. And so having some, first of all, having real humility and respect that we're kind of new in some sense, at least in terms of the scientific community, learning about and using this and experimenting with and so forth. So I think that's maybe the first attitude that we need to have. And I think, like a lot of our capitalist, colonialist sort of history of how we seem to take things from Native and other non-Western individuals and cultures to use it for our own ends, I think this is happening again. And so I think there's a way in which we need to really look at the kinds of practices and have a conversation about that, and how can we bring some sense of justice into the conversation, as well as being excited by the science. There's also the other side of it too, that there are people, and this happened in the first time that, when I think it was like the Beatles went to Mexico to visit with this woman, I'm blanking on her name, who is a shaman, and then all of a sudden, like, her village was like overrun by tourists, right? To like get to who the Beatles talking to in Mexico, and so that's just one example, right? But we can imagine this sort of exploding and really affecting people's lives and taking away from what they hold precious, and I think that's really an important piece as well.
Yeah, just following up on Craig's comments, obviously we want to respect other cultures just for just being better humans on the one hand. This conversation around psychedelics and particularly North American or American Indians in this space, it always strikes me as being virtue signaling and disingenuous, and as a punchline to, like, I'm a good person. And it's really, okay, if you want to be a good person, if we really want to take care of the American Indian or Native people, how about we start like acknowledging the bullshit we did to those cultures, and how about we start like giving them back land? And it's not here in these substances, because when we think about this, we have to think about things like the opium poppy. Who do we get back for that? I mean, all of our medicines come from these plants, but here in this space, we pretend to be good people by acknowledging that as a punchline. That's what that becomes. And in terms of just knowledge in general, we take from other cultures, cultures take from us. That's just how it works. You obviously want to respect the places and people that you take from. We want to do that just in general. But if we want to talk about doing right by the American Indian, we have to first start by acknowledging the horror that we perpetrated on that community. I mean, you can go and get a PhD in this country and not know how we displaced the American Indian. And so that's where the conversation should be, not with these substances, because when we have this conversation with these substances, it's disingenuous, and it's not the most pressing problem there. It's almost like saying, well, we want to make sure we do right by Black people. Let's call them African Americans. Like, no, that's not the problem. That's not the issue. And so I think we should focus on these substances, and we don't have to do that, because that's not what we're here to do.
So Professor Hart, let's talk about that. I mean, clearly, with although I won't say it for the university, with American Indian heritage, from my mother, and hearing about what they did, certainly about taking babies away in some families. There's horrible things. But do you not think, getting it back to our subject, do you not think we can learn from them about how they're using some of these substances? I mean, especially because you can have good trips, bad trips, or something, and have we learned anything? Should we learn anything from them? I mean,
yeah, I think we should always be humble and exercise some humility no matter what in terms of our quest to learn more. So I'm not suggesting that, but that kind of knowledge is not unique to American Indian culture in terms of how substances work and how the best sort of ways. I mean, because we know some things about substances in our society based on newer technologies and so forth. So I'm not saying that we should just ignore what people have learned. I'm not saying that at all. All I'm saying is that the conversation about us paying homage to American Indians in this space always just seemed as one of those checklist items. Checked.
Yeah.
And virtue signaling, and we do that shit really well at places like Columbia. That's what we specialize in, virtue signaling.
Yeah. So what have we learned? I mean, there were some early NIMH studies, that were done, and there's some newer studies. What is the evidence saying about the use of psychoactive substances?
I can say some things about something like PTSD. One of the more exciting things for me in this space is that PTSD is a difficult condition to treat, of course, and MDMA treatment seems to be by far the most effective thing at this moment. Certainly, it's in phase 3 trials. And several studies have demonstrated effectiveness with MDMA treatment. Various population, ex-military police officers have participated in these studies, and it seems as though MDMA will receive FDA approval within the next year or two if the situation continues as it is now. And so I'm excited about that area. Maybe Craig, maybe you have an area you're excited.
Yeah, I'm joined by another friend here. She's very excited also by this conversation, apparently. So I think in the palliative care space, something I was having a conversation the other evening, and we were talking about, well, why psychedelics, or why is this so exciting for the palliative care folks? Why not use traditional methods that get people to these states or of reckoning with their mortality and dissolution of their ego through, whether it be psychoanalysis or meditation or other means. And I think one of the things that's just that I've been struck by is just we don't have a lot of time often working with patients with a serious illness. So, if you're imagining someone who has months to live and is dealing with, significant depression or significant existential distress in the face of their mortality, and here comes a therapeutic intervention that with one, dose, with one experience coupled with the psychotherapy, can have a meaningful impact on their mental state. That's really exciting. I mean, so that we see that with ketamine in some sense. We see that with some of the psilocybin studies. The first 2 studies, these they weren't big, but they made a lot of noise in the press in 2016 when it was Ross's group at NYU and Griffith's group at Hopkins published these randomized control trials using psilocybin, and it really just was like, wow, this had a pretty profound impact. And so I think that's where those of us in palliative care started to see that, wow, you can really see some significant changes in depression and death anxiety, and existential distress. I mean, the existential distress, I should say, just as an aside, I think is a really interesting thing to talk about, right? Because we have, on the one hand, in some states, we have, legislation that allows for what's called physician aid in dying or medical aid in dying. And if you look at the individuals who often are seeking this kind of alternative, often it's in the context of what we would call psychoexistential distress, right? and we don't really have a good therapy for that. We don't even know how to define it in some sense. It's hard to tease it apart from other psychological states. And so I have a colleague of mine who's actually in Washington who's putting forth a case against the DEA, and is looking actually for, amicus, brief from physicians and others to support what's called a right to try, meaning that here's someone at the end of life, and where it's not legal to use psilocybin, for example, in the state of Washington for therapeutic purposes or just in general for one's use, and they're suffering from existential distress, and we have some evidence that this may actually be helpful for existential stress. So shouldn't that person and other individuals similarly have a right to try it, even though it's not considered legal? And so I think there's a way in which it has particular resonance in the field of palliative care and hospice because the time is so limited, and these drugs don't need a long time to have the profound effect that they're seemingly having in some of the studies that we're seeing.
So that really goes to one of the questions I had about should it clinician, if somebody wants to try this and has it, and it's not legal, and they get some psilocybin, should clinicians support this, and what really goes into psilocybin facilitated therapy? I mean, that's something that I was reading about, and what do clinicians need to know, or what should they be doing, or what can they do legally?
Greg, I think you should answer that one.
Yeah, I'll try. Yeah, I think there's a couple of things. One is, when we think of it from a therapeutic standpoint, remember these are not, at least the studies that we're looking at for the most part, are all done in the context of what's called assisted psychotherapy or assisted therapy. So it's the substance and therapy. So it's not just, handing someone, 25 milligrams of psilocybin and saying, okay, good luck with that. And I'll follow up with you next month. That's not what we're doing here. And so I think, first of all, that has to be understood, that it's possible that maybe these substances, when used on one's own, could have some effect, but it could also be, maybe lead to individuals being in states that they don't want to be in and not have the support of a therapist and so forth. So I think from a clinical standpoint, from a therapeutic standpoint, we have to think about what most of the folks who do this research and are involved in these kinds of work is set and setting. So in other words, thinking about, the individual's mindset and their intentions when they're engaging with this therapy, and the setting, the actual physical space and the psychological environment that's being provided for individuals. And so in some sense, that likely is mitigating, what people might call a bad trip, right? If you're creating a set and a setting that's ideally suited for someone to have a safe space for a dissolution of their ego and to explore states of consciousness that might allow them to have other connections about their lives, and then to allow that to be integrated through a therapeutic session with someone who's done some training and has guided individuals in this way. So I think in that sense, and that's what the studies have been showing us. So we don't have the evidence, at least yet, of it doing it in sort of isolation or people doing it on their own. Now we have lots of anecdotal evidence of people for hundreds of years, if not longer, experimenting on their own and finding these substances to be of benefit. But I think in the clinical setting, at least in the space that I'm in, what I try to do when patients express interest is I try to find a study that they could enroll in, ideally. There are practitioners outside of the United States, and there are some places that do offer psilocybin assisted therapy. There are some folks that are doing ketamine assisted therapy, which is legal. Ketamine, as most of us know, is an anesthetic, and has some properties that also, as Carl was saying before, it's not just psilocybin and the quote psychedelics. A lot of drugs have this potential of either a dissolution of ego or a different change of consciousness, and allowing, priming someone perhaps for a therapeutic experience that could be life-changing. And so that might be another option. So I might try to find individuals who are doing ketamine-assisted therapy and connect them in that way, or find them a study that they're interested in. Of course, there's a lot of things that are happening under the underground movement as well. But I think from a clinical standpoint, that's sort of how I've been approaching it and thinking about it.
May I ask a follow-up to Craig? Related to that question, I think the main thing for the public is how do you get access when you have this thing that's illegal. Because as you pointed out, ketamine, of course, is legal. And not only that, the price is for many people prohibited, ketamine itself, that therapy. So the question is, how do people who who gain access to the compounds that are illegal, one, and the ones who have lack of resources. Craig, I know it's a hard question, but so please don't feel like you have to provide the answer to that question. But it's just a question that people are asking.
No, absolutely. It's another thing that comes up in this space. I've spoken to a lot of individuals who are starting to branch out into creating almost like a specialized clinic where they're just doing this, right? And this can easily turn into another kind of boutique practice whereby those who can afford $1,000 ketamine infusion with some psychotherapy or more, or with these other substances, and go to Costa Rica and have a psilocybin assisted therapy trip. I mean, how many people can afford to do that, right? So there's that is an issue for sure. That's and it's happening. And so access and thinking about it, and also again, if we even go back to those studies themselves, one of the research gaps we have is that these studies have been largely done in white individuals in certain socioeconomic state, and that's just a reality. So we don't even have the diversity of patients or subjects in the research to really understand, is this going to be helpful, and to what extent might we have to modify it or work with different individuals and different backgrounds and communities and all the issues that they bring into the therapeutic space, right, into the clinical setting. And so there's a lot there that I think really needs to be unpacked as well.
Yeah, so I'm going to build on this, and then we do have a question in the chat that I'll bring up. But and I'm no expert, you two are the experts here, but what I read, it's mainly white subjects that have been, that have been in these trials. And what do we know about using these substances in diverse populations, and what do we need to think about?
Enrolling them in these studies. Sorry, enrolling them in these studies. I mean, really making an effort to make sure that we enroll individuals in these studies, and that they're not just I mean, I always think back to my 80-year-old Dominican grandmother who lives 2 blocks away from the hospital. What do we know about psilocybin for her? I don't know. It's never been tested in my 80-year-old abuela. It's just never been tested as far as I know. And so might there be some real benefit? Yeah, but we don't have that. They're not subjects in these studies.
Carl, you want to add on to that, or?
I can't really add anything to what Greg said. I absolutely agree.
So we've got to do better with our enrollment. So Gail has asked, what does the data show about ketamine's efficacy for end-of-life existential distress?
Yeah, I don't think there's a lot out there in terms of that specific. There's some case studies. There's there's some anecdotal evidence of folks using it, but there isn't, as far as I know, a controlled trial that's really looked at that possibility. I know that there's a psychologist that I'm aware of that I've been communicating with, who's very interested in creating a protocol using ketamine assisted psychotherapy for this population, for patients at the end of life, specifically with psychoexistential distress. So I think the data is just not there yet, but I think there's real potential, and it's something that probably should be used more. They're using it a lot, basing it off of the impact that it has on depression. And we know that IV ketamine or intranasal ketamine has can have profound antidepressant effects, and so that's sort of the encouraging. But yeah, I think we'd have to study this more rigorously, but I suspect that we would see some impact.
Yeah, Gayla says that Phil Wolfson is working on it, she thinks. I want to talk a little bit about synthetic psilocybin versus natural occurring psilocybin, and are there differences? What do we need to know about this, or is the synthetic psilocybin another way for the pharmaceuticals to get into this? Do you have any thoughts about synthetic versus natural? And what the pharmaceutical companies are doing.
I always think of these conversations as kind of, again, kind of artificial. On the one hand, sometimes the natural compound has, the natural plant has in it enzymes, chemicals that maybe enhance the activity of the main psychoactive compound, and that's good. And there's this interaction that's really important. And that's a good thing. Beyond that, if we have psilocybin that is active centrally, that's synthetic, as well as the plant material, I don't see the problem with having a synthetic compound. I know people talk about the pharmaceutical companies getting involved. It's like, welcome to capitalism. I mean, they're going to be here. If you have a problem with that, you have to deal with capitalism. And again, those kind of issue takes away from the real issues that we should be talking about. I know I'm not an expert in capitalism, and I don't want to pretend to be. And so as long as we have the system, yeah, people are going to be there to make money. And if we want to do something about that, then we have to do something about that more broadly.
Craig, do you have anything to add to that?
No, I think that's absolutely right. Yeah, I think that's right. I mean, we see it happening already. I mean, there's venture capitalists that are jumping, right into this, head first into this space, that are, hopefully, looking to profit off it. I mean, that's to be expected with a novel, research and sort of something that has implications like this, and has been publicized so much, since Michael Pollan's book even, and a lot of lay press has just really exploded. So that makes sense why individuals would want to get involved in trying to capitalize off of this. Whether there's a big difference, it's hard to say. I agree. I mean, some of these naturally occurring substances do require other chaperone molecules and other substances that are part of the natural plant, and so there's that piece to it. I mean, I think it also turns on something that we have a lot of deep assumptions about a kind of a materialist or reductionist approach to the world, and I think it's worth noting that a materialist or a reductionist, some would say, well, it's the molecules, stupid, right? It's like that's all it is. It's just the molecules interacting with these other receptors in the brain, and that's it. Well, okay, yeah, that's certainly a way of experiencing it, and there are whole other ways of understanding our interaction with the world, with what we call nature, or what we call plants, and so on. And so other healers or shamans might have a very different construct or a very different way of relating to the healing benefit and properties that these plants have, and see it as a sacred plant, right? And so I think that if you ask someone else, they might say, yeah, that's junk medicine, and this is the real medicine, but I'm not going to weigh in on that. I just think there are different ways of seeing the world, and I think we have to recognize our own assumptions that we build into how we consider these medicines.
Well, I think about it too from this issue of potency. For example, if you have a synthetic compound, and then you can enhance the potency at some level, and that meaning that you need to take less of it in order to have your desired effect. That's a good thing, because then it decreases the likelihood of these non-specific effects. And so all of those kind of issues have to be balanced as we consider this. But just a quick comment about the sort of capitalism angle here. If we look at what has happened in the country surrounding cannabis, another original plant medicine. If we think about cannabis and how we have gone about making it more legally available in some spaces. The legal availability of cannabis isn't being driven by like the right thing to do by our society. It's being driven by potential of making money. And so states have voted to legally regulate cannabis because they see the potential for tax revenues, not because you're arresting all of these people and disproportionately arresting Black and brown people, not because of that, not because of justice issues, but because of monetary issues. And so some states, what they've done, Illinois might be the best, I think, what they've done in order to try to do better at this and balance this sort of capitalistic instincts versus justice is that they built into their law these things where a certain amount of the profit goes to people who have been directly negatively impacted by what we were doing previously. So we can think about how we move forward in our sort of legalizing these compounds or making these compounds legally available in a similar way. So we can check out all of the different experiments that are going on in the various states and then try to improve upon that legislatively. That's one angle.
That's a great angle, and one I wanted to actually bring up, and you spoke to it very well, what we've learned from the legalization of marijuana. And so can you talk a little bit about, humane drug policies and what we should be doing?
Yeah, so when I think of, all right, so this is beyond the palliative care. Now,
Yeah.
we're talking about drug policy in general. It's a very simple thing. If we know anything about our founding document, the Declaration of Independence, many of you don't because you were required to read it when you were 10 or 9 and you don't remember it and it wasn't relevant to you. But I'll give you the sort of main point. The main point is that it says that each of us have the right to at least 3 birthrights: life, liberty, and the pursuit of happiness. With the sort of caveat that as long as you're not preventing other people from enjoying these rights. Now, life, liberty, and the pursuit of happiness includes people having the right to alter their consciousness, as long as they're not bothering other people. Bodily autonomy, all of those sort of things fall in our founding principles. So the question for me becomes, why in the hell have we been so restrictive with certain drugs and not others? And then, so if you go back and you look at history and so forth, if you look at like the tobacco companies, we weren't restricted with their compounds because they worked to get exemptions from their compound through all of the early legislations. And then we think about, why were we restricted with some compounds? Well, because they were associated with certain groups, certain racial groups, certain classes of people. And so we couldn't go after those people directly. So we went after an activity in which we said they engaged in. And so all of that sort of thing tells me that we violated our own founding principles. And so, first of all, our drug policy should at least try to live up to who we say we are. And then, so our job as experts in this area is to try and figure out then how do we keep a population safe and healthy with those goals in mind still, and if people are using drugs. And we can make certain drugs legally available, control the unit dose, quality, just like we do things like alcohol, and we can have requirements, age requirements, other requirements before people are allowed to engage in the activity, but the activity is available. And so the drug policy that we have has to respect those rights that people have. If our drug policy does not respect those rights, then we're starting at the wrong place. And our current drug policy does not, because we arrest 1 million people each year in this country for a drug law violation, and mostly the vast majority of them is just for simply possessing a drug, and it goes against who we say we are. Very basic, very fundamental. And I'm just trying to be a better American, live up to the ideals that we profess to guarantee.
In the Constitution. Craig, do you want to add anything?
Look, I mean, I have also very strong opinions about that too. I think there's a way in which clearly Professor Hart is very much right on most of those points, and I think that our policy and the lack of access and the legal the consequences of that is certainly something that I think is deeply problematic. I hadn't made that connection about thinking of it in terms of our right to happiness. I think that's a really important and an interesting line of reasoning. And it's something else that comes up, interestingly enough, in palliative care. You know, this is also you know, somewhat I don't know, thought of as quote controversial, is, you know, we're interested in alleviating suffering, but we don't talk about increasing pleasure as part of that mix. Right. If you think about the equation of, you know, a certain amount of pleasure and a certain amount of suffering, you know, would you know, lead to, you know, one state of being, right, a certain quality or a state of their being. Maybe we call it happiness, or we call it, you know, whatever. And so we don't really talk about that. We talk about alleviating suffering. What about promoting pleasure? And what are the ways in which we could do that? You know, and there's so much stigma around it. You know, if I have a patient who says, you know, doc, I feel like I'm getting a little high off of the oxycodone. It's like, all right, so, and like, why is that so problematic, right? Why, you know, what is so problematic about you feeling good, right? If it's not causing harm, I don't get it, right?
Craig, you should read a book called Drug Use for Grownups. It covers all of that sort of stuff. Exactly. That's all in there. And that's the point of the book, is that, you know, the idea is that if you feel better, if I feel better, I'm more likely to treat you better. It's very basic and very simple, but the thing that we haven't talked about is that our current drug control policy, as American taxpayers, we pay $40 billion a year to continue this policy. And that amounts to a lot of jobs. And so our current sort of drug control strategy is probably one of the most successful jobs programs in the US. And so if we're going to talk about changing the drug policy, we have to redirect the efforts of the people who are benefiting, because the current policy is working for a tremendous amount of people. I mean, I am a tenured professor here in part because of our drug control policy strategies. I've got $1 million grants based on the hysteria about drugs, and I published many papers based on this hysteria. And so, full disclosure, I participated in the nonsense, and that's why I wrote the book Drug Use for Grownups, in order to apologize and to come out and say the harm that I've done by supporting this position.
Thank you. Thank you. There's a lot of questions in the chat, but there's one specifically for you, Dr. Hart. It says, from what I understood, you suspect that the other psychoactive substances like heroin might provide similar benefits to psilocybin. Can you speak more to that thought or clarify what you meant?
Yeah. So in the book, Drug Use for Grownups, one of the things about the book is that I went on a tour around the world, 5 different continents, and did all of these psychoactive drugs, and as part of it. And so as Craig was pointing out, set and setting is important just for drug use in general. And so when you're in the appropriate settings, those settings itself can engender many of these effects. And so that's the point that I'm making. You certainly can get like ego dissolution with something like heroin in the right setting. And of course, and this is all predicated on the fact that you actually have the drug that you think you have. And that's another problem with our drug policy in this country. People don't have access to drug checking like they do in countries like Spain, the Netherlands, Colombia, and around the globe to ensure that they have the substance that they think they have. And so under those conditions, under the appropriate conditions, oh yeah, the many of these substances can engender many of these desired effects. That's why people use them. As Craig pointed out, people say that, yeah, I felt good. I got a little euphoric. I was always taught that, yeah, you want your patients to feel something good about your treatment because it increases the likelihood that they will continue it.
Yeah, yeah. But some of the research, that New England Journal of Medicine article that just came out, and this was not for palliative care, but other uses. 77% had adverse effects, some which were quite bad, and such as suicidal ideation or behavior and self-injury. And that was for the synthetic psilocybin. And what do you get? Is this safe? These are questions.
Well, I think we'd have to, first of all, in that, looking at that population that they were studying, right? This is a population with treatment-resistant depression. So these are individuals already that are going to be. It's not the general population. It's maybe having so that we're already dealing with a very unique population here. But yeah, I agree that it was, I think it was something like 7 to 9% in the higher, the 25 milligram group that had some had this significant adverse effect of suicidal ideation, and so yeah. So what do we do with that? We have to understand it more and sort of really do a rigorous understanding of in that are there factors, are there certain inherent things that we need to work screen for, and things like having a psychotic disorder, might that be more problematic? Clearly that's not something that a lot of folks would feel comfortable, prescribing these medications to, or people have had maybe other bad experiences with similar substances, So yeah, I think it just needs to be explored more. But I think at the end, these severe adverse events, they weren't as high as 77%. I think it was something in the less than 10% had a severe adverse effect, and I think it was like 3 to 6% or something like that actually had suicidality. So, but yeah, it's something we have to explore and to understand a little bit better for sure. But I think it's still safe. That's a fairly small minority in this very depressed group of individuals who are not doing well on second, third line treatments.
Yeah, the question really reminds me that. So I just taught my last class for the semester, and so we had a whole semester of building up to these kind of discussions. And so at the beginning, you kind of start off by saying that all of these psychoactive substances has the potential for positive effect and negative effects and so forth. It depends on a number of things, as Craig was pointing out, the history of the person who's taken the drug, dose, setting, all of these kind of things. So you contextualize those sort of things early on. And so in this space with the folks who are here, I'm assuming they know that we know that drugs have the potential for negative and positive effects. And so I'm assuming, and that might be a big assumption, because in our country, whenever you talk about any positive effects related to certain these class of drugs, then you are promoting drug use. And so I was hoping that we were beyond that with the group with whom we are having this discussion. And because that's really low level, we know that all substances have the potential for negative and positive effects, and you still have to do the work of figuring out the history, the dose, the setting. All of those always apply whenever anyone's taking a drug.
Yeah, no, absolutely. So getting it back to palliative care a little bit, are there certain psychoactive substances that are better for in the palliative care setting? Do we know anything about that? Or, psilocybin better than something else?
Well, they haven't been trialed one against each other, right? So, I mean, I think a really interesting trial would be to do a multi-armed trial where you have, a high dose of psilocybin, let's say 25 milligrams versus, a ketamine as another option, and sort of seeing, are there differences there? Does it matter so much which substance it is, or can you get a similar kind of benefit by inducing these altered states or these changes in one's consciousness, and by maybe a dissolution of the ego, coupled with really important, really integrated psychotherapy? And if that's the case, then it doesn't really matter that much, right? It's just a matter of, can we create positive experiences for individuals who are suffering and help them to get out of their suffering? I mean, I think that's really the bottom line, right? So to me, I'm agnostic as to which substance, and I don't think we have enough evidence right now. The hype is all on psilocybin, but there are a lot of other substances out there.
Absolutely. I'm with you, Craig, all the way. I mean, MDMA, a wide range of substances should be tested. And also we have to take into consideration a person's use history. I mean, their experience with these things, right? Because you might have someone who was a pain patient who's had opioids for an extended period of time and would much more prefer that. So it depends on people's history as well. So, but again, I absolutely agree with you, Craig. We need to study that.
Yeah. And then a lot of people have some questions slightly off, palliative care, and, such as veterans with PTSD or the use of the substance in alcohol or other drug dependence. Do we know anything about those other uses for these drugs? And do they work for other drug dependence or alcohol dependence?
Well, the veterans question, the MDMA studies have included veterans, and it's been shown to be beneficial. Alcohol, there's a group in England who's studying alcohol use disorders with MDMA, and I think they're reporting some encouraging findings, but I don't know whether or not they have reported it in the literature, but I know they're studying that. So that's the extent of my knowledge for those questions that you just asked.
Okay. Yeah. We're almost at the top of the hour, and so I want to give you each a chance to last thoughts, other considerations, something we didn't talk about that you'd like to say. Go ahead, Craig.
Well, no, I don't. I mean, I'm just thinking about this term integration, and how do we take what we're learning in research spaces, what our current drug policy and culture allows for, and the therapeutic settings that we operate in, and it's really going to be tricky to figure out how to do this. And I think we have to be really creative, maybe even changing significantly some of the ways in which our so-called healthcare system operates and functions. And this might open up a potential for really rethinking some of the clinical care spaces that we operate in. And maybe palliative care is a nice test tube or a crucible to sort of work this out in, because the time is short and the stakes are pretty high. And so there might be an opportunity there to imagine, again, to bring in the pleasure and to bring in increasing people's state of their quality of their life, and not just sort of going after disease states, but actually thinking about what is it that we're doing here on this planet. Right? We have only so much time, and what do we do with it, and how do we help others who are struggling during this time that they have? So I think that, to me, is really so I'm so interested in this idea of integration and taking what we know on a biochemical or a clinical space, and seeing in what ways could we change the practices and our attitudes, most importantly, about this stuff.
Thank you. Carl?
Well, I don't want to screw up Craig's words, because they were so beautiful, particularly the part that we only have a short amount of time here, and we're trying to enjoy ourselves and treat people well. And Craig said it a lot more beautifully than me. So I just like people who are on this bizarre as medium Zoom that we're doing this thing. I just like you all to think about, when you hear the word like controversial, because you'll hear those kind of things in this space. That should be a cue for you to be really critical of the person using the word controversial. is the person dealing with data? And that's what the currency here is, data. What do the data say? I don't really care what people are saying. What does the data say? And people's labeling of things as controversial is done in order to bias you towards one way or another. So check out the data, number one. And number two, as we see this sort of rethinking of psychedelics in our society as defined by the popular culture, as we see the rethinking of these substances, please remember what we said and how we vilified these same substances not long ago. And then as you think about how we vilified these substances not long ago, think about the substances that we are vilifying today. And then so it's a clue to you to know that if you've been lied to previously, is it possible that you're not being lied to now? And so that's why we're in these spaces, to think critically, and that's part of it. And I want to leave you finally with just the sort of promise of our original promise, the founding promise of the country, that each of us have the right to life, liberty, and the pursuit of happiness. If people are not disrupting other people's ability to do that, why do you care what they do? If you do, that's your problem. Something's wrong with you. So please keep that in mind. Live up to the country's original ideals.
This has been really, really great, you two. Thank you both. People hang on till the end. We're at the top of the hour, but I can't thank you both enough. So thank you. It was really.
Thank you. Thanks for having us. Thanks for talking today, Carl. Really enjoyed it.
Thank you guys for organizing it. And Craig, you know, you and I, we're going to take this on the road, bro.
There we go. I'm into it.
Bye-bye.
Take care.
Take care, guys. Take care, everybody. Bye-bye.